Good morning, everyone. Good afternoon. Welcome to another VMR today. We had double treat. Right now, we're going to be discussing with our dear teacher, Dr. Ravi, and an amazing case presenter, Sasan. And I'm very happy to see you all here. I have been a little bit absent for this past month, but yeah, I hope that you're ready for a Sasan case. Dr. Ravi, would you like to say something?
Oh, I'm very excited to be back. I was away last week doing a board review. So I have a lot of board review pearls, but in clinical reasoning, it's not as simple as a board review question. So these cases are complex. So hopefully I can get back on the saddle and put on my clinical reasoning hat and happy to join Yaz in this next venture. So, and I want to introduce Sausan, who is going to present a case. So how you been, Sausan?
Hi, I've been good. Thank you for asking.
Should we get going?
Yeah.
Sure. Okay, so this is a case that was shared with me. We have a 44-year-old maid who presents with a high-grade fever of 1-day duration. And I'm going to stop here.
Ooh, fever. I love it. I think that I had been volunteered for, for something that I hope that I'm not anchoring an ID, but whenever I listen to high grade fever, the first thing that we might think about is high grade inflammation, and that can be caused by an infection, of course. But not everything is infection. I will try not to anchor here. Another thing that we can think about is there are drugs that can induce hyperthermia. There are other causes, such as if this patient had been on a hot weather outside, and this might be a heat stroke, or some patients with dehydration, some people with post-transfusion, some people with pulmonary embolism even can cause fever. So it's a very big differential diagnosis. And if we go to the infectious diseases, well, we wouldn't even finish. We have to determine exactly the source to be able to treat it. But that would be on my differential fever versus hyperthermia. On the hyperthermia rationale, we can think about acute brain injury or endocrine causes such as atherosclerosis or adrenal crisis. And also there are other drugs that can cause issues such as malignant hyperthermia, or even like earlier, if some of you joined, serotonin syndrome or neuroleptic malignant syndrome. But yeah, I think I have spoken too much. What do you think, Dr. Ravi?
Oh, I just love your approach. You're thinking, okay, let's not go with the typical discussion that we've had on CPS, but let's go with the more indirect approach. So you named a couple of different things, and you also have recalled recently the case as this morning with fever, and we were talking about psychiatric emergencies. But I would just like to say, number one, number two, number three, infection. So this is a very common presentation to the hospital for those of you that are doing clinical work or doing any sort of postgraduate training. You'll see fever coming into the emergency room. But sometimes these patients do get turned away for some reason. There's maybe the identification of a possible complication of a fever. Like you mentioned, fevers, you may get cold at night. I do this talk with the residents about fever, and you get this one-off fever at night. So everybody has some sort of temperature dysregulation. Nighttime, you may spike a temp, but that doesn't mean there's an infection that's evolving. So at night, everybody sort of may get warm, may get cold. So one-off fever doesn't mean you're going to do a full infectious workup, but I think a trend of temperatures is an alarm symptom. I think it would be alarming for infection. And then you have to go through the possibilities of what kind of infections do we worry about. Yes, we get into who is the host and the immune system and so on. And yeah, if Sausan says this patient has HIV, is on a steroid possibly, then we really have to start thinking of atypical infections. But at this point, I know I taught this to Yasmin. I usually rely on GRUB-C as my mnemonic. Why? Because there was a paper in the Journal of Infectious Disease, which they did a survey at a hospital in Pennsylvania, in about 400 patients, they found most common infections will be number one, UTI, number two, or is it number one, pneumonia, number two, UTI, gastrointestinal syndromes, which would be all the itises. So like appendicitis, cholecystitis, duodenitis, diverticulitis. So whoever came up with the term itis did us a favor. So it's very easy to recall those. And then in the GRUBS mnemonic, B is bacteremia, S skin soft tissue, R, I guess, was respiratory, so pneumonia. And actually, I asked a friend of ours who was downtown for infectious disease, asked him about if he would improve the mnemonic, and he said add C. So C for CNS infection, but that would be once you've gone through the most common infections, and C, because it's more invasive, you have to do an LP in that case. But yeah, I would start there. Anything else, Yaz, before we send it back to Sausan?
Yeah, I just wanted to add this pearl that I got from an ID rotation is that fever by itself should not make us anchor in ID per cell. But if we see rigors and chills, that's when we start to think to prioritize infections over anything else. I might share the paper on the chat. That's another thing. And definitely localizing where could this be coming from is a good point of approach. But yeah, let's hear more about it, Sausan.
So this is a previously healthy male who presented to the hospital with the fever. The fever ranged between 39 degrees and 39.5, and it was unresponsive to antipyretics. The fever would decrease but wouldn't go back to normal. And he denied any other symptoms initially. And he was admitted for further evaluation, and a septic workup was started, which included blood cultures, chest x-ray, urine analysis, and urine cultures, which all came back negative. And empirical antibiotics were started. And I'm going to stop here.
I guess I'll take a stab at this, but I didn't mention the I made D squared E mnemonic, which I think is also a very powerful tool for beginners. Why? Because I'll give you a scenario. I had a patient that everybody thought had an infection, and I made you stop at the endocrinopathies, and it actually was a mimicker of an infectious process, which was adrenal insufficiency. The other was the drug-induced, so D squared, DVT and D drugs, and serotonin syndrome. I saw one case of serotonin syndrome, and it looked very much in a patient that was on chemotherapeutics, and it looked very much like an infection. So it's a very powerful mnemonic to use, or a tool in trying to decipher. But let's get to the crux of this case here. Oh, it went red there for a sec. But this patient is unresponsive to pyuretics. What would this mean? At this point, I don't have any reference to sort of fall back on, but just thinking common things commonly. If somebody's not responding, either their burden of inflammation is just so huge that antipyretics aren't working, or that the antipyretic is not being effective. I would have to kind of look that up in this case. So are there also certain scenarios or certain conditions where antipyretics may not work? So could this be a fever not of an infectious etiology, but the mechanism of fever? I just kind of did put something in the chat. If you look at the pathophysiology, it's an inflammatory process, right? The bacterial endotoxin triggers through interleukins the thalamus, and then you get that set point temperature regulation in this case. But then antipyretics should work through that process. So could this be something outside the pathophysiologic process of interleukin-induced fevers? So I'm kind of limited there, but I'll swing the mic to Yasmin to see if she has any thoughts about this.
Definitely. Now, thinking about an unresponsive fever, first I would look, this is quite high fever, right? And maybe it could be such a high inflammatory process that's why this patient's immune system cannot decrease this degree of response, or the empiric antibiotics in this case is the wrong one. So I think that one of the how we can pivot this approach is to determine the source. So I definitely agree with the chest X-ray, urine culture, look at any site of any rash or wound or anything in ears, eyes, absolutely everything. And in good ID fashion, we'll be starting to ask absolutely like if they have sick contacts or contacts with animals, if they have pets, what type of pets, if they are vaccinated, if they have traveled, where do they work? Maybe that could be a way to like look for any exposure, and from there try to like dig a little bit more on it. Now, it mentions that if it doesn't return to normal and it keeps going up and down, I'm also thinking if this has a pattern, because there are many different types of fever that responds to a pattern. And it will be interesting to like create a log. Just as another thing I learned was with people that have multiple sclerosis or issues regulating their temperature. Many times we think they have an infection, but sometimes it's just a dysregulation. So maybe a fever log or a temperature log, I'm not really sure how you call them, would be very useful to determine if what kind of infection can it be, or if this is due to another process. I'm wondering if we should get more information.
Yeah, I just want to, you just touch on a really interesting thing there. I was just thinking back to, remember Ravi's and Keaton's case of the Castleman syndrome, in that they were talking about Hodgkin's lymphoma and so on. So you tend to get with Hodgkin's, Ravi had mentioned Pal-Epstein fever. So you sort of touched on these eponyms where you have these fevers. So you have relapsing fever, you have undulant fever, biphasic fever, malaria has a sort of intermittent fever as well, continuous remittent fever, and so on. So you're right. I don't know how much sensitivity do they have for diagnosing an infection, but it's something that could help your pretest probability or could help clue you into what kind of disorder they may have. And that could be not just infection, but autoimmune phenomena and so on. So it's a very interesting process, I guess, condition or association you touch on. And yeah, let's get some more information from Solsan to see if this is relevant to this case.
Okay, so I'll give you some more information about the course of the course of illness. The fever persisted, and on day 3, the patient developed abdominal pain, right upper quadrant abdominal pain, that was severe, dull, aching. Some information, he has hyperlipidemia, but he's not on any medications, and he smokes shisha occasionally. I'm gonna give you now the vitals. His temperature was 39 degrees, heart rate was 105, blood pressure was 118/77, and respiratory rate was 16. And on examination, like abdominal examination, he had a soft, lax abdomen, but with right upper quadrant tenderness, but there was no swelling or like abdominal distension or any other remarkable finding. Would you like me to give you the labs, or should I stop here?
I think, yeah, let's stop here. I think the exam is very interesting. What do you think, Yaz?
Well, whenever I hear right upper quadrant abdominal pain, I'm thinking, well, could this be something in the liver or biliary tract and or pancreas? Like we can discuss that side. Of course, visceral abdominal pain is so unspecific, but it can give us a clue of what to look for. If I listen to this, I would definitely be asking about any possible infectious disease that are prevalent, like that has a certain affection for liver, such as like, do you have you been exposed to mosquitoes? Malaria is one of the biggest ones that have like fever that persists. But I also will think, does this person have any exposure or any issues that could make me think, well, something might be going on that liver? And my reflex would be to ask for liver function tests, for bilirubin levels, for calcium, maybe lipase or amylase. I'm wondering on those two, but that will be for starters. That's my initial reflex. But also I'm wondering why this patient only has these two things. I'm still having trouble trying to shorten the DDX so far. And if I'm being honest, if I'm thinking of liver and biliary tree, I would expect jaundice or something else, but so far everything is normal. So I'm thinking, what your approach would be?
Yeah, I don't know if this abdominal pain, the right upper quadrant, is a significant pivot point, but now it allows us to focus our attention to a particular area. Remember, we talked about the grub CG, so itis, and of course the chat is going wild over possible cholecystitis. And to have such a high fever, what is the worst scenario complication of cholecystitis? Would be cholangitis, ascending cholangitis. But those patients are extremely toxic. And I would expect at least patient having hypertension or signs of sepsis. And I see the blood pressure 118 over 77. But then again, these patients, they're evolving while they're presenting. So at the index point of presentation, patient will be stable. In another hour, their blood pressure may be down to 86 over 50, MAP less than 65. So this could very well could be evolving ascending cholangitis. But you're right, where's the jaundice? We're not seeing that. Could that be, again, evolving as well? So we're going to look for the bilirubin, indirect bilirubin levels and direct bilirubin levels. And to at least have jaundice, you would look for levels above 4, 6, somewhere around there. Sclera probably about 4. So no, wait, 2 and 4 to 6. Some books I've seen 6 for jaundice, systemic jaundice, but no altered mental status. So that, that pentad that you always learn for ascending cholangitis, you don't always see it. I've had patients that are fully mentating and having ascending cholangitis. So it probably, you have to wait some time before they manifest with the altered mental status. So yeah, the area of interest is the right upper quadrant. The fever is indicating likely inflammation, infection. I think we've met the pretest probability to do some imaging to push this forward as the likely leading hypothesis. So I would at least be interested. Yes, labs will supplement this hypothesis that we're trying to prioritize, but then also imaging, having an ultrasound would be very helpful at this point. So I'll swing it back to you, Sosan.
Okay, so the white blood cell count was normal. Hemoglobin was 17.1, and the hematocrit being 48%, and the platelet were 180. As for the inflammatory markers, the CRP was 20, and ESR was 40, which are considered elevated. Liver enzymes, I don't have like numerical values, but I know they were slightly elevated. But for the bilirubin, they were like with the normal limits. Hepatitis workup was done, which included hepatitis A, B, and C, which were all negative. And infectious causes were also like ruled out. And I have a question for you. What would your next step be? What would you order?
So for me, reflexively would be a USG of liver and biliary tract. Even if we have it mildly high liver enzymes, I'm thinking we should not like discard any processing there. My first differentials, of course, will still be an acute cholecystitis or any biliary issue, maybe a hepatic abscess. Even I would, and this hemoglobin for some, like it's too high. So I would keep on the back of my mind any polycythemia or myeloproliferative disorder. Although it does not typically present with abdominal pain, I will still keep that in the back of my mind. And having such a high hemoglobin will also make me think about Chiari syndrome. I know it can be very obscure, but this can be presented with right upper quadrant pain. We can have hepatomegaly. We can have, this is of course a rare condition, but still having that on the differential. Another thing that I would add into my abdominal ultrasound, aside from liver function tests that we already have, would be blood cultures. But that's my reflex. What do you think, Dr. Ravi?
Yeah, I love that thought of blood carrier syndrome. Yeah, what's interesting is there's no white count. So what does that mean to us? So either one, it's just a matter of time before the patient manifests with an elevated white count. Maybe the whole inflammatory process hasn't had a chance to occur yet. The other thing is maybe we're not dealing with infection. Maybe we have to start considering other causes, something outside the right upper quadrant area. So yeah, could it be the liver? The liver enzymes are a little elevated, they're a little perturbed. So and then thinking about organisms, is it really bacterial? Could there be viral? The hepatitis panel is negative, but you have to start thinking about other things, EBV, CMV, that could also disturb the liver and it can cause a massive amount of systemic inflammation, fevers as well, that are continuous. And I've seen it in one patient where it's not responding. So then you have to start thinking about other conditions. We haven't really gotten any information about their immune status at this time. If they're immunocompromised, that maybe that's why their white count isn't elevated. The CRP ESR is a great way to have sort of a look into the patient's immune function. So they're a little elevated, but not terribly. So maybe we can use this as a point of reference for championing our thought of an infection that's occurring in this patient. The other thing is abscess, like you mentioned, that's a great thought, right? So what is an abscess? It's walled off from the body. So this abscess is not allowing the immune cells to like get in, and the immune cells are sort of sitting outside and like, hey, let me in. But then there's this thick wall that's cornering off this purulent material. And when you poke a needle in it, suddenly I've seen patients that you poke a needle, it opens up, and then the white count shoots up, and they become terribly septic. So maybe that could be something that is in contention. So at this point, yeah, I think imaging definitely will be helpful. You mentioned a hepatic abscess. So there was a case one of my friends told me, like, there was a case of their family member going on a marathon run, had a marathon, next day was feeling really sick, had a fever, went to the ER and had imaging done and had a hepatic abscess, no bacteremia. So that case is still evolving. So it could happen. So definitely imaging, ultrasound, CT, whatever we can get, that will be appreciated. Anything else, Yaz, before we swing the mic back to Sosan?
Just a point that I forgot to mention, that maybe also assess the hydration status of this patient, because it could be hemoconcentration too. So we should like rule out that case. Again, a 17 of hemoglobin, as many people in the chat have mentioned, could be because there's a patient who smokes, but still, I think that it wouldn't explain this fever.
Oh, yeah, great point. I forgot about that. Yeah, smoking. I don't know. You have to smoke quite a bit to have secondary polycythemia. So yeah, you have to wonder if this is primary polycythemia due to elevated, I guess, due to polycythemia vera. But we don't have anything in the history of aquagenic pruritus. So this would be secondary, and we do see quite a bit of hemoconcentration. So give some fluids and see what happens. The hookah, interesting association. But I don't think it's something that you continually smoke for years and years to cause polycythemia.
Okay, should I give you the ultrasound findings? So they did an ultrasound, abdominal ultrasound, which revealed thrombosis of the posterior branch of the portal vein. And the finding was confirmed with a CT angio, and an MRCP was done, which didn't show any other like abnormality in the biliary tree. And there were no like intraluminal gas or any inflammatory changes surrounding the thrombus. And given the diagnosis of portal vein thrombosis, a thrombophilia workup was done, which included protein C, S levels, antithrombin 3, and prothrombin gene mutation analysis, lupus anticoagulant, and PNH, which were all negative. And I'll stop here because the next aliquot will reveal the final diagnosis.
Oh, wow. I put thrombosis. I'm not thinking about portal vein thrombosis. My mind goes to like, what could have caused this? And I'm thinking like this, if this patient, normally I would expect this on patients with cirrhosis or that have any collagen vascular disease, such as lupus, or that have hypercoagulability, like in malignancies. Also thinking this inherited thrombophilia, as I mentioned, protein C and antithrombin 3. I really don't know which are the high levels of it or low levels. In this case, I would expect like high levels of protein C and S to find out if this is the cause that this person has an inherited thrombophilia. Although it's a knowledge gap for me to think if this patient already had an inherited thrombophilia, why he hadn't had any issue before. He's 44. I would expect any hypercoagulable symptom previously. And again, myeloproliferative diseases can also cause portal vein thrombosis. So that would be part of my etiologies for this presentation. But yeah, what do you think, Dr. Ravi?
Yeah, it was very interesting because usually if what I was taught last week at board review, portal vein thrombosis is not as significant like Budd-Chiari syndrome you mentioned earlier. And it's usually in the presence of decompensated liver cirrhosis, but here we don't have any signature of liver cirrhosis here. So what else could do this? Hypercoagulable disorder possibly. But again, this patient wasn't terribly, just had fever, but nothing else. But some slight abdominal pain, I would imagine it would be bad, but usually portal vein thrombosis patients can be asymptomatic. Tumor malignancies is something I would be interested in. Could there be a malignancy in the background that causes this? Some malignancies can be very hyper or prothrombogenic in this case. There's a high likelihood having a hypercoagulable condition due to thrombosis. The PNH is interesting. That goes with Budd-Chiari. It tends to cause both arterial and venous thrombosis and can manifest with Budd-Chiari in this case. But the rest of the hypercoagulable workup, I don't think portal vein thrombosis, the hypercoagulable workup usually is associated with that, unless liver cirrhosis you can tend. So if the thing that you mentioned, I also mentioned liver cirrhosis, you do tend to be hypocoagulable or hypercoagulable. It just depends which part of the seesaw you're on. At one point you could be hypo, the other you could be hyper, because the first proteins to go are protein C, protein S, which are liver generative factors. And if protein C, protein S is gone, you can get like the warfarin associated skin necrosis with Coumadin, or you can get clots like this developing. So it's kind of interesting, but I would, at 44 years of age, I would consider thrombosis in this patient. Think about malignancy in this patient. Yeah. Back to you, Sosa.
Okay, so what they did was they did JAK2 mutation testing, which came back positive, and he was diagnosed with a portal vein thrombosis secondary mutation, and he was started on direct oral anticoagulants, and the fever subsided within 48 hours from the and that's the case.
Sorry, Sosan, you cut out JAK2 and it was a myeloproliferative disorder?
I'm not sure. I just know that the genetic testing was positive for it, and that was the diagnosis.
Okay, so like JAK2 could be, we talked about polycythemia vera, myelofibrosis in this case, and then essential thrombocythemia. JAK2 could be positive. There are other markers that you also do, but JAK2 would be positive. Out of the myeloproliferative disorders, CML is not one, if I remember, that has JAK2. But I wonder which one of those, because the platelets, the hemoglobin's elevated, and Yaz had alluded to that previously, so I just wonder. An EPO level would be helpful. If EPO level's low, that would help you in trying to get that diagnosis. But there's nothing in the history to say like having aquagenic pruritus, having plethora, and so on. Yeah. But but it is very interesting. You have to look. What I would do is look for cases like this and see if there's something similar, which kind of MPN could cause portal vein thrombosis. What do you think, Yaz?
Yeah, definitely. I am honestly, this is amazing. Like I was not, I know that Sasana told us that it was very short case, but I think that we went through a lot of things here. It's good that I didn't anchor an ID, but yeah, everything every time I listen about myeloproliferative disorders, especially polycythemia, I think I remember about the aquagenic pruritus. I'm wondering if this patient have had this kind of issue before, and would be like, I am itchy, but I don't really mind it. Or if there were any other signs that maybe were always there, but nobody or even the patient didn't realize. And after this, I think that I will put this patient on a, depending on his spleen, splenectomy, or maybe depending on cytoreduction with hydroxyurea, or even on the, how do you say, this antiplatelet drugs such as aspirin to avoid any thromboembolism, any future thromboembolic event. So yeah, I think that this was a very good case. Thank you so much, Sasan.
Yeah, thank you, Sultan. That was a fun roller coaster of a case. I think I will have to think about it later today and see what I can learn from this case. So really appreciate you bringing this.
It was a great discussion. Thank you.
And then we should move on to Vinicius, who's kindly doing he did scribing this morning for Neuro VMR. Now he'll do teaching points. So appreciate your work today.
Oh yeah, so let's try do this. So after we started the discussion and talking about fever, and mainly the first thing that we want to do is differentiate between inflammation, infection, and hyperthermic causes of fever. And some examples that can occur with clinical manifestations of that is heat stroke, dehydration, possible endocrine causes, adrenal causes, malignant hyperthermia, serotonin syndrome, and also we could not forget about the toxic causes. Afterwards, we need to understand that fever doesn't is not a synonym of infection. So that's an important thing to consider. And if yes, you consider infection, you need to look for what kind of infection is and who is the host and what type of atypical infection could be if this is a real possibility. And then we went to discuss the most common causes of fever, and the most prevalent. We need to differentiate between systems, so we need to consider UTIs, some possible inflammations such as cholecystitis and other itis and things related, and other respiratory tissue related causes such as pneumonia, bacteremia, soft tissue could also be a cause, CNS, endocrinopathies, and finally drug-induced. But when we do think about rigors and chills, we need to prioritize infection, and after that, we need to briefly think what is the localization or the pattern, if it is continuous or intermittent, if it walks in veins, and here the tempo also matters. And so then we could not we could see that the theater could not respond to antipyretics, and this could indicate that is an interleukin induced fever, or if this is a high inflammatory process. And then we need to establish what is the pretest probability of the possible causes. And then, yes, just pointed that uh, we need to evaluate the, the pretest probability. And the first would be cholecystitis, the second would be myeloproliferative diseases, and she also mentioned it, but Chiari. So then we need to proceed with some imaging and labs, and chest X-ray would be pertinent during cultures, and we need to look for rash, sick contacts, animal contacts. Where does the patient work, and if she or he has travel history and possible exposures. And then we also could see about the abdominal pain, and there is some very specific, and for example, a pharyngitis could cause an abdominal pain, and then we need to try to characterize in a specific area and think about the prevalence. That would help us a lot. And after that, it is pertinent to proceed with some labs such as liver function tests, amylase, calcium, bilirubin, CMP, CBC, and we could see that the patient had a high hemoglobin concentration, but no signs of polycythemia such as plethora and aquagenic pruritus. Finally, we could also perceived about the area of interest that was limited as a right upper quadrant. So we need to think right away in cholangitis, but the patient had no jaundice. So what else could be? And we need to investigate about liver causes. So liver, when we think about liver, we need to think about the bilirubin pattern, and if we have some organs that can cause the clinical manifestations, such as the EBV, CMV, hepatitis, and systemic inflammation. So then we could see about the CRP and the ESR that are labs that would help us to look for some immune function. And we could also see that abscesses are a very important differential diagnosis here, and they cannot let the immune cells enter the site, and these can evolve for sepsis quickly. So imaging is essential subsequently, and we need to look for causes of thrombosis such as malignancy, lupus, polycythemia, thrombophilia, myeloproliferative causes, decompensated liver cirrhosis, PNH, and other hypo and hypercoagulability states. So finally, our patient had a JAK2 positive manifestation, but few clinical signs that, and these make our diagnosis very difficult. Basically that. I'm sorry for the delay.
Oh, wow, Vinicius, that you extracted so much teaching from this case. It's amazing. So I was just listening to you. It's almost like a lecture of this case. And I think the highlight of this is, yeah, the MPNs, and to look. I also have to wonder about the JAK2 association, like an ANA. Could this signal MPN or not? So we probably need more information or more diagnostic workup. What's interesting, I looked it up, and that it is very difficult to diagnose patients with MPN at this stage because of other confounders. So that may be why the next step is going to be very difficult. So that's why probably, because splenomegaly may occur too, this patient could have essential thrombocythemia. The platelets aren't elevated because it could be in the spleen. But what's interesting, the most thrombogenic of these is polycythemia vera. So this could be, like Yasmin alluded to initially, the hemoglobin. Is it real? Is it not? A EPO level, SOSAN, would be very crucial in this case, and would be a perfect exam question for step 2 or the board exam. So the EPO would differentiate between primary or secondary then. All right, great. Thank you very much. Great job, Vinicius. Thank you, Yaz. Always great to discuss with you.
Thank you so much.
Have a great rest of your day, everybody. Take care. See you tomorrow. Bye.